Okay, we're back at it, and this is lecture 71 on electroencephalography, EEGs, and evoked potentials, and we're going to look at brainwaves, so it's kind of cool. So generally, the physio lectures are pretty fun, so I like it. Anyways, so we have the EEGs, electroencephalography, EEGs, are the measurement of voltage fluctuations on the surface of the scalp, and it's generated by brain activity, and these voltage fluctuations are brain waves. And so electrical voltage, you can kind of think about, remember, just from a physics point of view, is kind of like electrical pressure almost, right? If you have a lot of electrons in an area, they push on each other, and so you would have a voltage, right? And so as you have these circuits going on in the brain, the voltage fluctuations, like the relative distribution of positive and negative charges, are going to give us our brain waves. Oops. So with that, we have, how do we actually go about measuring this? We have electrodes that get placed on the brain, standardized placement. The voltage that we measure is incredibly small, 10 to the negative 6 volts or microvolts. Think about your toaster that might use 2 amps of current, operate on like 120 volts is our standard outlet, and our EEG machines are going to amplify this signal in order to allow detection and recording, and then we use something called a Fourier transform to analyze these voltage waveforms that we get, right? All right, so then how do we actually go about reading EEGs? They have 3 main aspects that we care about. So brain waves at different frequencies. We have alpha, beta, theta, delta waves. We also have gamma waves, and we'll get to those in a second. Specific patterns of specific types of wave patterns, which is a little bit more complex, and we're not going to be looking at it in this class. And then you have artifacts on these ECGs, which, just like in ultrasounds, it's not meant to be there. It's disturbances due to technical defects, due to movement, or maybe sweat, something that's keeping, adding noise, a signal that should not be there. All right, so then the Fourier transform thing we mentioned is basically you take in this, raw data, and you can use Fourier transforms to analyze that data. You have the voltage versus time that makes up these waves, and you can essentially use Fourier transform to make it intensity versus frequency. And so intensity is proportional to amplitude, but basically you can see if you're looking at frequency, waves are inherently defined by, their frequency. This is, not the perfect example of this, but think about light, right? What separates visible light from another type of light, which is radio waves, right? It's just the frequency of the wave itself. So frequency is going to be really our determining factor for what type of wave we have. And then if we use a Fourier transform, we can go from the sort of raw signal to figuring out what percentage of the waves are at a different frequency. So what percent are delta, theta versus alpha wave versus a beta wave versus a gamma wave overall. All right, so goal is to determine, if you have a whole bunch of raw data coming in of voltage versus time, what proportion of that is gamma, beta, alpha, delta, theta, or delta. All right, so we have the categories of brainwaves we're told about, and there's like a decent amount to know here, but overall, I just want to start off by giving us a nice little mnemonic from our friend ChatGPT. We have gamma, beta, alpha, theta, delta. They are separated by their frequencies. So gamma has the highest frequency, right? And then if you can remember a tiny bit of physics, we recall that we have gamma waves, or gamma rays is typically how we describe it in terms of light. That is a type of light, right? Of a very high frequency, and it happens to be the most dangerous one, right? Radio waves are another type of light, and they're the lowest frequency. So here we're taking brain waves, we're describing them by frequency, and just like with light, the most dangerous type of light has the highest frequency. We're not saying that gamma rays are dangerous, but we're just saying gamma has the highest frequency, okay? So our mnemonic is great bears always take dance. Great is for gamma. It's greater than 40 hertz, right? Then we have beta, which is 30 to 40 hertz. Okay, and hertz you can think of as, hertz is a measure of frequency. So say I have this one point right here, and then I have this wave that's going to come through that point, right? And so if I were to just measure at this particular point, and I'd say, hey, I have a little detector right here, how many different peaks of the wave are going to hit this point in 1 second, right? And that gives us our frequency measure. So how frequently the like the peak of the wave is passing a particular point, right? So it's just a way of like measuring, categorizing these different types of waves. So we have great bears always take dance. Cool. So what's going on with our gamma waves, given that it is the brainwave with the highest frequency? Well, it's the widely spread out, what it shows us, widely spread out areas of the brain are active at the same time. Those are displaying these gamma oscillations, gamma waves, same thing. Gamma frequencies are thought to reflect what is called binding, which is a property of the brain that unifies our awareness into a single gestalt, so basically allows us to kind of think. It's not visible on EEG tracing, so you have to use the Fourier transform to say, hey, there's a huge spike right here. This is the frequency of all of your brain data that we're getting that is the most common, okay? It's not necessarily the case here. It's just saying that that gamma is the most common. It's just saying you have to use a Fourier transform to see gamma on an EEG tracing. Okay, or rather, you can't see it on EEG tracing. You have to use a Fourier analysis to get a secondary graph, or then you can say, oh, there is a gamma wave here. All right, the next one is bears for beta, and these are low frequency, higher, or low amplitude, higher frequency waves. It's maybe absent or reduced in areas of cortex damage, cortical damage. It is the most dominant rhythm in patients who are alert or anxious and or have their eyes open. All right, so beta, bears, alert, anxious, and have their eyes open, maybe just like having a bear in front of you, you would certainly be alert or anxious and have your eyes open, I would hope. All right, or maybe your eyes are closed because you're like, oh no, it's over. No, we don't go that route. So we're going to say beta waves are dominant rhythm in patients who are alert, anxious, or have their eyes open. Then you have alpha waves. And again, from high frequency to low frequency, great bears always take dance. Always for alpha, 8 to 13 hertz. And alpha is best seen in the posterior regions of the head on each side, having higher amplitude on the dominant side. It is brought out by closing the eyes and during relaxation. So alpha waves are associated with relaxation. It is all right to relax. So alpha waves, major rhythm seen in relaxed adults and present during most of life, especially beyond the 13th year. Dominates the resting tracing. All right. Then we have theta waves, which are 4 to 8 hertz. So again, that would be like 4 to 8 crests of the wave passing our sensor at one point. Frequency, how frequently the crest of the wave is passing a point in a second. It is theta waves for take are abnormal in awake adults, but it's normal in children up to 13 years. And theta waves are generally present in sleep, but normally seen in the hippocampus, which cannot be detected through surface EEG readings. In the hippocampus, theta is thought to represent activation of the hippocampus. It's seen as a focal disturbance in focal subcortical lesions, okay? So we wouldn't normally see it in awake adults. So if we see it in awake adults, if we see theta in awake adults, that would not be good. All right, so then we have delta, and these, just like gamma, are generally broad or diffused, maybe bilateral. They're high amplitude waves. Delta are not present in normal adult EEGs. It is a sign of disease. So great bears always take dance. Theta is sleep. Gamma is you can't see it, sort of unified awareness. And beta is alert or anxious. Alpha is relaxation. And so gamma, sort of alert, unified awareness, highest frequency. Beta, you're alert or anxious. And you can kind of see, a general trend as you decrease in frequency towards, right, relaxation, sleep. And then this is so low frequency, you could describe it as like spikes. This is something is wrong, right? You should not see that delta, less than 4 hertz. Okay, so not too bad. Then we had the concept of EEG brain topography, and this is basically just creating like a 3D map of an EEG. Basically use tons of electrodes, more than you normally would, and you can use it to detect early acute intracranial complications in the intensive care unit, screen for epileptic seizures, evaluate for dementia, pre-surgery evaluation, or signs of cardiovascular disease, because, right, if you say had like a stroke or something and you have ischemia and an area of your brain has died, well, you're not going to have very much of voltage fluctuations in that area then. All right, so causes of EEG signals, we've kind of already mentioned this, but, we have our neurons are firing. So in particular, though, we have sort of the wave itself is kind of rhythmic. And so that suggests some sort of synchronicity or some pace setting, perhaps. So we have the thalamus, which you remember is our relay station of the brain. and it's really connected to all the different parts of the cortex, connected to pathways coming up from the spinal cord. But between the thalamus and the thalamus and the cortex, we have feedback between layer 6 of the cortex. This would be the neocortex, which most of the cortex is made of, and then the thalamus. An example of this feedback is you have the lateral geniculate nucleus, which you remember from our optic pathway. We have the retina sending fibers to lateral geniculate nucleus of the thalamus, and this only makes about 20% of the afferent input to the lateral geniculate nucleus. Another 40% comes from the primary visual cortex of the cortex, and then another 20% is coming from the reticular activating system, thalamic reticular nucleus, or interneurons. But the idea is that you have constant in and out of the communication between like the thalamus and then the cortex. So thalamus, cortex, back and forth. And so you have these action potentials that are cycling between these two regions. And so you have sort of a rhythmic, the beginning of a wave, right? So you sensory information from the eye, then to the cortex, then to back to the thalamus, then to the cortex, back to the thalamus, overall. And so you have this particular nucleus inside of the thalamus called the thalamic reticular nucleus, and this is going to regulate thalamic nuclei rhythm, because the many different nuclei that make up the thalamus, and I apologize, this picture is useless because you can't see the labels, but this red part right here is meant to denote the thalamic reticular nucleus, and it is going to help regulate the thalamic nuclei rhythm overall, so the rate at which they're firing. And so basically what you end up getting is you have these rhythms sort of follow two functional modes of the thalamus. We have the tonic or tonic mode, and then we have the burst mode. The tonic mode is associated with being awake, but basically you're conveying action potentials from sensors in the body to the cerebral cortex, and it occurs during REM part of sleep, and then, as we said, being awake. But it's when the thalamus relay neurons are depolarized, they've been activated, is our tonic mode. And then we have burst mode, which is associated with being in non-REM sleep. It's rhythmic, bursting, spikes. It alters information flow to the thalamus, right? You don't really necessarily want all of your sensory information to go to the cortex for analysis if you're just laying there sleeping, right? So burst mode is associated with sleep. The relay cells become hyperpolarized, so it's kind of the opposite of tonic mode. All right, and then so if tonic is associated with being awake, and then random eye movement sleep, which is kind of like being awake, but you're still in sleep, and burst modes. So the shift between these two modes, tonic and awake and sleep, is controlled by the reticular nucleus of the thalamus and the reticular activating system, which is located in the brainstem. But the reticular nucleus of the thalamus, well, we've already seen him, right? The thalamic reticular nucleus. He helps set up this thalamic nuclei rhythm, which they communicate with the rest of the cortex. The other nuclei communicate with the rest of the cortex. The reticular nucleus of the thalamus, these neurons are inhibitory. They hyperpolarize thalamic relay cells, and so they can cause basically the thalamus to enter burst mode. And then the reticular activating system is going to inhibit these reticular nuclei neurons and activate the thalamic neurons, relay cells, and cause you to go into tonic mode or awake mode. And so the reticular activating system consists of the pedunculopontine nucleus, PPN, and lateral dorsal tegmentum, LDN, in the upper pons and spinal cord of, well, pons is part of the, excuse me, my gosh, my brain has died, in the brainstem. So pons is brainstem, lateral dorsal tegmentum is also brainstem. Okay, so synchronous conduction in thalamus cortical loops underlies EEGs. Basically, the brain waves are a result of the brain's activity at cellular level. That makes sense, hopefully. And we have brain waves are generated when populations of brain cells depolarize in coordination with each other in synchronization. The extreme examples of this, so we said beta waves are bear waves, right? You're anxious, you're alert. Task-dependent synchronization in active brain areas, rapid low amplitude indicate coordinated activity of relatively smaller populations of neurons. This occurs during tonic mode. Delta waves, again, is more, burst mode is more associated with sleep. So, as we get to alpha, relax, theta, sleep, and delta spikes, so delta is associated with burst mode, relatively large populations of neurons conducting in synchrony through the thalamocortical loops, okay? But the EEGs mainly detect activity in the gray matter of the cortex. and the voltage changes are actually the sum voltages acting on pyramidal cells of the cortex, layers 2, 3, 5, and 6. Do you need to know that level of information? No, just know that it's like the sum of the voltages as a result of the sum of these action potentials acting on the neurons. And so that would be the EPSP and IPSP, the excitatory postsynaptic potential, inhibitory postsynaptic potential. Just think of it like the summation of the action potentials is really what's being measured, and that would be not the action potentials themselves that's being measured, it's the summation. So EPSP and IPSP is a great distinction. Honestly, I'm not sure if it's really necessary. You know that, but maybe it's a test question. All right, so then we have evoked potentials. These are also called event-related potentials, ERPs. And so you're like event, okay, something has happened. Potential, you think voltage. So you're thinking event-related voltage. Okay, so these are EEG signals that result when the brain is exposed to a specific activity, an event. The activity can be sensory, thinking, cognitive, or motor, moving, right? Sensory provoked potentials, sort of start with talking about that, or it's what we're going to talk about because it's a little bit maybe more straightforward. So if you expose a subject to repeated sensory stimuli, again, repeated basis, and you record an EEG, then you can say overlap. Say you have one EEG, right? And then you have another EEG. And then you can basically, if you have multiple recordings, this is from doing getting poked once, and this is getting poked in the exact same place again. And so now I can like overlap them, and I can find out, and average them. And if I were to average them, then I can find out, helps me get rid of all of the noise, the signals that aren't really associated with the processing of that event, right? So the idea is if you expose a patient to repeated event, and recording EEG, you can look at evoked potential, aka event-related potential, by averaging the EEG recordings because you've taken multiple recordings, and then you get this new graph, the event-related potential graph. All right, so this is our EEG. We've taken we've recorded it multiple times. All right, so the way that they've set up this graph is here's one recording, here's another recording, here's another recording of the stimuli, here's another recording of the stimuli, and we've averaged these all together, and you get this new graph. And this is the event-related potential, all right? And so here's the thing. We're going to, before we look at this, let's just look at the parts of this. So how do you actually read one of these guys? You have various deflections, right? These ups and downs, these peaks, right? These are the deflections. Here's a deflection, here's a deflection, here's a deflection, here's a deflection, here's a deflection. These are called components, and we label them P or N. P is assigned to peaks that are pointing down, and N is assigned to peaks that are pointing up. Then we are giving them a latency or time. Latency as in think of like a lag, right? So it's a lag after the event started, right? So I poked you here, and then this is what your brain did at this latency. This is what your brain did at that latency. This is what your brain did at that latency, right? And so you could say, okay, well, the latency of P1 is 175. Okay, so we've associated with different times. So we have, again, each of these components, various deflections, P for peaks pointing downwards, N for peaks pointing upwards, and then latency are time values given to the events, the components, the peaks on the event-related potential graph. And so if you are in early latency, right, this is when I poked you, if you are in less than 150 milliseconds, so if you're in this region right here, we would say this is subcortical processing zone, right? What is subcortical? That means that the stimulus has come up, it is in this region right here, okay? So this is less than 150 milliseconds, it's being processed in the subcortical zone, okay? So early latency values less than 150 milliseconds indicate processing the stimulus in the subcortical zone, this zone, okay? If you're late latency, so past 150 milliseconds, you are now in the cortical processing zone. So all of these components, P1, N1, P2, N400, P3, these are all latencies greater than 150 milliseconds. That indicates that this is an action that the brain has taken. This is a voltage that the brain has shown in the cortex versus subcortical. All right, so this kind of makes sense. I hope it would, because right, you have your sensory information coming up the brainstem, going to our thalamus, right, a relay station, and then it's eventually going to go to the cortical region. So it makes sense that the brain would do something first in the thalamus and the subcortical region, and then eventually get to the cortical region, right? So basically, again, do we need to know how much more information past this? Not really too much. The goal is if you see some like weird, maybe like a whole bunch of spikes, you would need like a reference graph to compare it to. But we know that this information applies to the cortex. And if we see abnormal features, then we'd say, hey, there's something wrong with the cortex. And if there's abnormal features here in less than 150 milliseconds, then you're like, okay, there's something wrong in the subcortical processing of this particular stimulus that we have given to this patient, right? So you combine it with the stimulus information in these evoked event-related potentials, right? You poke them, you're like, oh, this is poking them, versus, hey, move your arm. And it's like, oh, okay, well, something with the subcortical, him moving his arm, versus cortical processing of him moving his arm, it's a little bit different, right? So it's a diagnostic clue. All right, so then what are the clinical usages of EEGs? Basically, the idea is this is a useful diagnostic tool because it is fast, right? You can measure brain events on the scale of 1 millisecond. PET scans, for instance, also looking at the brain, take about 30 seconds to make. And then the EEG is used when there's reason to suspect pathology related to a change in brain function. So epilepsy, sleep disorders, stroke, right? You might have some part of the brain that is now dead due to ischemia after stroke, not getting enough oxygen, head trauma, or brain tumor. However, it's very important to know EEGs are not useful for detecting psychiatric illnesses like depression or schizophrenia. All right, so then the main use, or one of the main uses, is diagnosing epilepsy. And you may remember epilepsy from basically abnormal brain like action potentials or abnormal brain function that's giving you strokes, right? And so many people with epilepsy don't have lesions, but they have abnormal brain activity. That's what I was trying to say. EEGs have abnormal brain activity, and for somebody with epilepsy, with an EEG and somebody with epilepsy, you can determine the foci of where the seizure starts in the brain. And so if you could identify the foci, then perhaps you can get a more targeted treatment for this particular case of epilepsy. And so you can divide basically how you read the EEGs of patients with epilepsy into two categories. There's interictal, and ictal right here is the important part. Ictal means seizure. And then the other category of EEG readings are ictal EEGs. All right, so basically not having a seizure EEG and then recording while you're having a seizure EEG. All right, maybe somewhat surprisingly, it's the normal interictal EEGs that are actually useful. The ictal EEGs are not super useful. So that when you're having a seizure and you're recording an EEG, that's not as helpful as if you were to record an EEG when you're not having a seizure. Okay, that seems a little strange, but let's go through it. So normal EEG, aka not having a seizure, recording is called an interictal EEG because ictal means seizure and inter means between. So we will see interictal abnormalities in the absence of seizures as spikes. Okay, so you will see spikes for somebody with epilepsy in their normal not having a seizure, aka interictal EEG, at a frequency similar to delta waves, right? So around 4 hertz. And these spikes are pathogenic. The location of the spikes can be subcortical or cortical, and they will be around the foci of the seizures where the seizures originate. And so if you have one foci, that would be a focal seizure. If you have multiple areas where it seems it's originating, that would be a multifocal seizure. And if it's wide areas, it's diffuse seizure. So it can allow you to identify the type of epilepsy as focal or generalized, and that will change treatment. Okay, so you'll see spikes on the interictal EEGs for somebody with epilepsy. And it will look a little bit like delta waves, but remember we said delta waves are great bears always take dance, and delta waves are spikes, and they are not normal. They are pathogenic, right? So spikes, not normal. We should not see those. And ictal EEGs, aka seizure EEGs, are recorded during seizures. They show widespread brain involvement, so you can't see the foci. So it's not as useful for determining the foci of the seizure. Is it useful overall? Perhaps, but for the purposes of what we're looking for is, do they have epilepsy? Where's their epilepsy's focus or loci? The answer is no. So here's just an example of the EEG reading. And so this is a weirdly, unfortunately not well described chart for us in the lecture. So this is an MEG, and this is a magnetic encephalography. Remember, EEG is electroencephalography. And if you remember from the physics point of view, every time you have electrons moving, it causes magnetic force, right? And so here you have your EEG, and electrons moving are going to cause magnetic force, which is going to push other electrons. And so this would be another reading. It's the magnetic encephalography. It's just the magnetic component of an EEG signal, okay? Why would they need to give us that information? I guess just to let us know that it exists, but we don't care about that. EEG is what we care about. We're going to look at it in just a second. We also have an ECG here, which is the electrocardiogram, all right? Why would they put this on this graph? If we're trying to learn about EEGs, it's just, this is a heart reading, right? Okay, and then you're just like, okay, we care about spikes, and it's like, well, here's a huge spike. That is your heart beating spike, right? Do not be concerned with this, okay, at this moment. So we're trying to look for spikes for somebody who has epilepsy, right? And again, what should our normal reading look like? We have alpha, beta, theta, delta is abnormal. So alpha is our relaxed state, beta is alert and anxious. So ideally one of these two, right? But they're high frequency, right? And here again, frequency is like we said the number of waves, peaks that pass a point in a second, right? And so if they're really high frequency, that would be like hitting the sensor really fast. So like I can't even do it. But if it's low frequency, it's hitting the sensor like tick, 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 right? So the delta waves are slow. They're abnormal. They're spikes, right? Like over here, this is more normal. The tiny, the distance, they're high frequency. The wavelength is super short. These are all spikes right here. Okay, and it's hard because they didn't really point out on the graph for us in lecture where the spikes were. These are the spikes. Okay. The other hint we get here is that this is 94 seconds. This is 95 seconds. So this range right here is 1 second. That means that right here to here, this is half of a second. All right, that means from here to here is a quarter of a second. That means from here to here is a little bit less than a quarter of a second. So maybe we'll say it's about a fifth of a second. All right, so we'll say that's a fifth of a second. But frequency is defined as 1 over period, right? So period is the length between the peaks of the wave. So we have the time length between here and here, 2 spikes, is about 1/5 of a second. So I do 1 over 1/5, and I get, in this case, it'd be 5 over 1 over seconds. 1 over seconds is the units, and hertz is equal to 1 over seconds. So we would say that this is approximately 5 hertz, which is similar to a delta wave, which is a spike. Delta waves are pathogenic. This is pathogenic, right? These, we should be seeing, these should not be so spread apart, even though it looks like they're close together. But again, this versus this, right? This bad spike. This may be more normal. All right, so that's it. I hope that was helpful, but keep at it. I know that this has been a stressful time for people, fire hose on steroids and whatnot. So good job, guys, and we'll see you next time, and I hope you're doing well.